Good morning, everyone, and thank you so much for joining us for the PATH LAN on understanding IHS Strategic Aim Number 3, Care Transitions. As a reminder to everyone at the PATH Leadership LAN, our tools and resources are always available on our website. Just visit healthinsight.org/PATHLAN 2019. I'm your facilitator for today, Francesca Flores. You can find me in the chat box and chat privately to me at any time. If you need any help, you can also chat with Elaine via our chat monitor. Our speakers today are Mary Erickson from Mountain Pacific Health and Sarah Leake, also from Mountain Pacific Quality Health. Our agenda today is quite tight, but we're hoping to get through it all and help you all understand more about AIM 3 and some of the baseline data that we've been collecting on this. Before we begin, I'd like to introduce Jonathan Merrill, Acting Deputy Director for Quality Healthcare and Indian Health Services.
Hey, thank you very much, Francesca. And really, since the last time that I think we've talked, that acting in my title has now been removed. So that was effective right before the government shutdown, and the Office of Quality has officially been announced in Federal Register notification in late January, and the Office of Quality is formally established as a permanent fixture within the Indian Health Service. So we're extremely excited about that. We've also aligned some staff under the Office of Quality. The IPC program is now formally located under the Office of Quality, and many of you all have probably seen that we've announced 5 positions out of the Office of Quality in our first round. And we hope to grow the Office of Quality to about 39 staff in the next 2 to 3 years as federal appropriations flow through from our legislative appropriators. So we're very excited about that, and we're also excited about our intra-agency partners and our partners at CMS and at PATH, and the important work that's been underway with PATH. I just want to recap a little bit of the aims that we've developed, and remember that we've co-developed these aims in concert with our area directors and CMOs. We had planning sessions back in mid-2018. And I think we've developed some strong and aims that will move towards sustainability and the design of really critical systems within our IHS facilities. I'll just recap. Aim number 1 was essentially improving safety and reducing risk by 50%. Aim number 2 was to put systems in place for sustained compliance and improved adherence to accreditation and regulatory standards. And this aim number 3, which is to put systems in place to assure hospital transitions across our care continuum, which is very important. I think everyone on the line understands the mobility of our patients, the reliance that we have on higher levels of care and specialty services, and ensuring that our patients have smooth transitions, don't get lost at handoffs, don't get lost through the PRC programs, and that we're following and tracking and have really high reliable systems in place to ensure the appropriateness of those transitions is critical. With that, I welcome everyone to the call. Look forward to the work occurring under AIM 3 and the improvements that it's going to help bring to Indian Health Service and our patients and help fulfill our mission. With that, I think I'm at my 4 minutes, and I know there's a very packed agenda that you guys have, and I want to turn the work back over to you, Francesca.
Thank you so much, Jonathan. We really appreciate you on, and that's very exciting news about the Office of Quality. We look forward to our continued partnership with you. So now I'm going to hand it over to our first speaker, Mary Erickson, as we talk about care transitions.
Hello, everybody. So I'm Mary Erickson from Mountain Pacific Quality Health. I work up here with our facilities primarily in the Montana region. I am the AIM-3 work group lead. So we have a work group that's made up of staff from CMS, IHS, and the PATH project that kind of tries to oversee the activities of this AIM. So that is what Sarah and that's why we're presenting to you today. And I encourage you to reach out to us if you have any questions after today, and hopefully we can clear up. This is a complex AIM with some complex measures, but hopefully we can clear up some of your questions and concerns that we encountered during the baseline data collection. So AIM-3, as Jonathan had said, was developed in collaboration with IHS and CMS to give some additional direction to the PATH project work. And it is to identify systems in place to assure hospital transitions. So he highlighted how important that was or that is. And so I won't elaborate more on that. I think we can all agree on that. So at this point, the care transition AIM has multiple measures to support this goal. And we have placed those measures into 4 groups: emergency department discharge planning and patient follow-up, emergency severity index accuracy, emergency department throughput time, and the left without being seen rate and patient follow-up. The baseline data collection was completed during the course of the last quarter of 2018, and there were about 10 hospitals that were able to report in that last quarter. We greatly appreciate the time and effort that they took to do that. And I think that it's really important to also mention that that baseline data collection process was as much a process of discovering your current processes and how you're doing these things already, because these were we found a lot of places are already doing a lot of great work in these areas. So I'm happy to highlight that today and collect that. So go ahead and go to the next slide. And so we're going to first look at emergency department discharge planning. So the overall ED discharge planning data that we captured, the first measure is the post-discharge plan, and we'll get into the measures a little deeper here in a minute. But first, to just take a look at that high-level data, compiling all of the hospitals that were able to report. If you were not able to be included in that first baseline data collection, we have data that's been submitted after that. That is from the start of the year that we'll include in the start of the year going forward. So we did kind of have to make a hard cutoff with that first baseline data collection. So no worries if you've submitted it. We have it, and we are working on putting things together for that first part of the year as well. So we'll talk more about that. Sarah will talk more about that. So the post-discharge plan, about 88% of the patients received a post-discharge plan, but I think it is to be noted that all reporting hospitals had a process in place to distribute the discharge plan. But what most of them found was that they hadn't really been monitoring compliance with that distribution to the patient of the plan, and so that's where that 88% comes from. So already the hospitals that we talked to were starting efforts on making sure 100% of those patients were getting their discharge plan. The next 2 measures are around post-discharge contact, and those were both at 6.3%. And you can see that the number of patients for those populations for those measures that was submitted was the same. And I'm going to talk about why that maybe should be a little bit different when we get into a deeper dive on those measures. You can go ahead and go to the next slide. So measure group 1 with the ED discharge planning in that first measure. The original measure definition was that 100% of patients discharged from IHS will have a post-discharge plan by December of 2018. So we've updated that definition of the measure to be 100% of IHS hospital emergency department patients with a discharge disposition of home health, or nursing home will have a post-discharge plan in 2019. And we changed it to include those discharge dispositions based on the feedback that we received from hospitals during the baseline data collection process. It was felt pretty strongly that admissions or transfers, of course, are going to have a completely different process for discharge plan. And it was believed by the work group that the intent of this measure was to make sure those patients that went home or home health or nursing home, which is essentially their home, had a discharge plan in place. So let us know if you have any questions on that updated definition. So your numerator criteria is documentation that indicated the discharge plan was provided to the patient. And your denominator is now emergency department visits with the discharge disposition of home, home health, or nursing home. So the measure target, and you will get all of these slides, so don't panic if you're not remembering everything. You'll get all of this, and this is also being recorded. So the measure target is 100% of patients, and the measure timeline is now July of 2019. So we did clarify with our work group that consisted of IHS and CMS staff that they wanted this to continue. It just said baseline data collection. They want it to continue into 2019. So go ahead to the next slide. So the discharge follow-up measure was originally defined as 100% of patients discharged from IHS will have a post-discharge contact within 2 business days. That has been updated to 90% of IHS emergency department patients with the discharge disposition of home or home health, and that should also include nursing home, will have a documented attempt of phone contact within 2 business days. Again, based on feedback during the baseline data collection process, we needed to provide some clarification on what constituted follow-up. So if you decide to use a different method, if you're more advanced, if you're using secure messaging or something to follow up with patients, please let us know. We're not trying to be prescriptive with these measures, but we are trying to find a balance of guidance in how these things should be measured. The 90% is also to help a little bit with that burden of having to follow up with 100% of patients, and also to start to take into consideration patients that may not leave contact information, and you may not be able to get a hold of them. So we're trying to leave a little bit of leeway there to take into account those kinds of things. So your numerator criteria is going to be the documented attempt of phone contact within 2 days of discharge from the emergency department. We recommend also that you prioritize, look at your ESI levels of your patients and prioritize your follow-up based on their complexity and what they came in with as well. So try to prioritize that, because we know this is a heavy lift of a measure to accomplish. So make sure that you're working with your PATH project manager and looking at your data and prioritizing your improvements and building your process around some priorities for your patients. The measure target is 90%, and that timeline that I apologize is cut off on this part of the presentation is July of 2019. Next slide. So this measure should really be a subset of the previous one that we just mentioned. So one thing that we're going to have to watch, because this measure is really for those patients that have a required provider follow-up documented in the ED encounter. So in theory, it should be a lesser amount of patients than is in the previous measure, but what we might find is that your ER providers do actually want follow-up on all of your patients. So if that's the case, then you know, we might want to just take that into consideration when we're looking at these measures and defining them and working on them. So in theory, it should be a subset, but it may turn out that it's not. So again, your numerator is that documented attempt of phone contact, but your denominator here is a little bit different in that it also includes that required provider follow-up has been documented somewhere in the ED encounter. We were finding that it wasn't always a part of the discharge plan, but it was somewhere in there. So we didn't want to be prescriptive and say it has to be in the discharge plan if you already have a process in place that says provider follow-up is required, you know, somewhere else in a note or in a template. So that's why that's written that way. So again, we recommend you prioritize your patients and look at your data with your PATH project managers to figure out your best process for achieving that 90% follow-up goal by July of 2019. So now I would like to go ahead to the next slide and introduce to you Jason Wood, ER supervisor at ACL Service Unit, and Melissa Wayako, the director of nursing at the service unit. They have done some amazing work around discharge planning. We wanted to give them an opportunity to just highlight that in a couple of minutes here. You'll see that we do have some data from them in January, February, and that was because they were identified as a best practice and chose to submit that data to us and share it with you all. So I don't want other people to panic and think they should have submitted that data. So go ahead, Jason.
Good morning, everyone. My name is Lieutenant Commander Jason Wood, and my supervisor, who's in the back behind me, is Melissa Wayako. We're part of the team that's worked on the emergency room discharge planning here at ACL Service Unit. If my voice starts to break, I've been sick for a couple of days, so I apologize. As far as the life cycle of the discharge instructions, which is what we called the project here at ACL, this started back just before the end of the year in 2017, when we were tasked at putting together a discharge instructions process here at ACL in our emergency department, because discharge instructions just weren't going out. We took about a month and reviewed what was available, what was being used in other facilities around the nation, what we could find on the internet, and we looked also into Indian Health Services facilities. There was a very good process being used at Phoenix Indian Medical Center, and I worked with our CAC here at our facility, and we had thought about traveling down to see how they gave out discharge instructions, but we were able to do everything remotely. And it turned out that the system that they had in place wasn't going to work for us because it wouldn't interface with our electronic health record templates that we use here at ACL. So what we did is we took a step back and we decided that we were going to design our own process for putting out discharge instructions. What that consisted of was looking at how we were going to go about compiling all the data that would potentially be used for all the potential diagnoses that happen in emergency rooms, patient diagnoses, and also looking at how we were going to communicate that to the patients when we were trying to give out discharge instructions. What we ended up putting together was a discharge template, which is a template that interfaces through EHR with data that is entered by the providers, but also has a field where the nursing staff, once the patient's diagnosis is entered into the system, the nursing staff can go through our approved medical databases. They can pull out information that is specific to the patient's diagnosis, and they can cut it and paste it into this discharge template, which can then be printed and given to the patient and reviewed with the patient before they leave the emergency room. It's a very streamlined process. Like I said before, it pulls some of the data that is entered by the providers when patients are seen in the emergency room, but it also has a field where the nursing staff can enter data from an approved database that has discharge information about whatever the patient's diagnosis was. All of this took about 5 to 6 months to put together. We worked with all of the potential stakeholders at our service unit, from medical records, billing, all of the different folks here in the executive level who would have some need to have input on this. And once it was approved, we rolled it out. Our February of 2018 data, we were at 100%. Now that was the first month that we rolled it out. We dropped off a little bit over the last few months, or over the months that moved forward from there. But we basically put this out to the nursing staff and said that we wanted to make sure that 100% of our patients got this. I know that our January and February data was 95% for January and 96% for February. To answer the question of how we might try to maintain that, this is a measurable element in the nurses' yearly annual reviews. And this is also something that we can track working with our CAC, because the template is trackable in the EHR dashboard. So that's a very shortened, brief overview of how we do the discharge instructions. And now I'm going to move aside and let Melissa come in and talk to you about the post-discharge communication with the patients.
Hello, everyone. My name is Melissa Vallejo, and I'm the Chief Nurse Executive here at ACL Hospital in Alameda, New Mexico. So for our post-discharge patient follow-up, what we had done way back in March was that we were seeing a lot of left without being seen. And so in January of 2018, we had like 56 patients who left. And in February, it was about close to 43, I think. And so that was a huge number. And so one of our inpatient supervisors who was willing to take this on and started calling patients up who were leaving and asking why they were leaving and if we needed to get them back into the hospital. And so we started following up on our post-discharge follow-up as far as what was going on with them, if we needed to bring them back, and we started collecting our data. The other thing that we had done was we had but we put in a nursing contract to have a ER case manager or a care coordinator to look at all of our discharges. That included left without being seen, AMA, and started calling them up and started collecting the data to see what was happening. And it was, so it was very enlightening that part of the reason our patients were leaving was because the wait was too long. And then the other portion was that they either saw other patients who needed to be seen ahead of them because they were sicker, and so they left and said they would come back early in the morning. The other thing that we instituted too as far as the post-discharge was the same-day clinic. So if we had providers in our primary care area who had open access, we would put them in and look at patients and bring them in and get them seen the next day. Or if not, if their conditions subsided, we made sure that we asked them how they were doing and documented all of their complaints documented their chief complaint and ensured that their complaint was resolved. Other than that, we have continued to keep up with our data every single day. We have a template that was generated, and it's it's called ER emergency room left without being seen template. And so the care coordinators use that, or she uses that to document her telephone conversation. That includes if we're able to get with the patient or not, or if it's a telephone call where they have no discussions, that we still document that the telephone call was attempted. The second initiative was to look at the follow-up with a provider in their discharge plan. And so the template was generated as well, and it's also called the ER emergency room discharge follow-up appointment telephone call. These two templates were originally generated by our quality manager and our CAC, and then our care coordinator in the ER and myself tested it. We made some revisions on it, and we started using it this past month in February. So we'll start capturing our data based on the template, the same process that they use for the discharge planning template. Our data for the month of January, compared to what we had last year as far as left without being seen, our numbers were 22, and then in February it was 29. So there has been a significant drop from when we started collecting our data to where we are now. So we have been able to capture that, and then now we're looking at our ESI levels as far as how we're going to capture that and putting it in a performance improvement plan and determining the accuracy of it by looking at it, looking at their chief complaint. But that's how we've been doing our discharge plan.
Yeah, thank you so much. You guys are doing some amazing work, and you are generating several chat questions, which we don't have time to answer right this second, but we've left some time at the end. So we'll try to get those, and if we run out of time today, then we'll get those questions via email and then distribute them to the group if that's okay. All right? All right. Thank you so much for sharing that wonderful information and work that you're doing. I hope that was helpful in giving people some ideas on how they can be successful at this process the way you guys are. So moving on now to the ESI. So go ahead to the next slide. So as we kind of expected, we knew that there was a lot of ESI review and accuracy already happening in the service units. So most hospitals were already doing this. As you can see, 90% of them were already doing some type of sampling, and the overall ESI accuracy rate for the 8 hospitals that reported this data was 93.6%. So that's really close to your 95% goal. The area that could use some improvement was including the ESI review in the monthly QAPI. So go ahead to the next slide. We'll talk a little bit more about that. So these measures didn't really change too much. We did have to separate this original measure into two separate measures. So this first one, we didn't have any changes to the actual measure definition. All we did was break it out into two measures. So this is the number of IHS hospital emergency departments that reported completion of the random sample for appropriate triage, which most hospitals were doing. So go ahead to the next slide. And then the second part of that is the number of emergency departments that included that ESI review in their QAPI program. So our goal is to be at 100% of hospitals doing both of these things by July of 2019, and we're super close to that. So I think that we'll be successful there. Go ahead to the next slide. And so the last one is just the ESI accuracy rate, and the goal for this in the original measure definition was that 100% of federally operated CMS certified hospitals providing services will have a 95% accuracy rate for ESI by July of 2019. And with the baseline at 93.6, you guys are super close to reaching this across the board. So we don't anticipate a huge amount of support in this area. However, if you go to the next slide, we just wanted to clarify that the one area that people did have questions was around how to gauge appropriate triage. And so really you need to be utilizing the AHRQ ESI decision tree. That's where the emergency severity index comes from, is from AHRQ. So using your process essentially for evaluating this would be using retrospective chart review and the AHRQ decision tree. You would evaluate the ESI level for the patient at the time that they came in. And then of course, hindsight's 2020. So you would be able to then look at the visit and say, okay, did we estimate correctly the amount of resources, the risk situation, did we assess the patient appropriately for their orientation, their pain or distress? And then does that hindsight of 2020 at the end, and those resources and all of those things that go into that ESI level, would the ESI level of somebody who's looking back on it be the same as the person who assessed it to begin with? So that's really kind of how you would gauge that. There's a lot of additional training, posters, videos, and materials on ESI levels and everything that we've included here. And we'll also have some additional education on that in April. So that is kind of the feedback that we got, was more guidance was needed in this area. So if this doesn't clear that up for you, join us in April, and we'll have a subject matter expert to also help with that, and reach out to your project manager and let us know what you need. So right now I would like to move on to introducing Nicole Lenore, the nurse manager at Quentin Burdick Memorial Health Facility in Belcourt. And she's going to just talk to us briefly. They stood out as a facility that was already reviewing ESI as a part of their QAPI process. And so we really wanted her to talk for a minute or two about how she was able to do that, and what do they do, and what improvements are planned for 2019. So Nicole, we'll take it away.
Hi, good afternoon. So just doing some research back into the old files here in our emergency room. These measures, or these performance improvement project for the ESI, was already in place before I came on as the ER nurse manager. So it was developed, and it looks like it was implemented in early 2014, where they would, monitor for triage accuracy. So the process, our QAPI process right now, is that we have the ESI form. So we've got a paper form that we send out to our PI collectors, what they're called. So on a PMAP, participating in QAPI, so they get credit, so they get credit on their PMAT for participating and being a reviewer. So they complete a random review in the emergency room, and I just ask that, be sure to include all staff in all different ESI levels. So they only review the triage note, and they document what they would assign as the ESI level and what the triage nurse documented as the ESI level. So, sometimes they'll write me a note with a bit of an analysis on it, but otherwise that's really sort of up to me and the nursing supervisor leadership team here to sort of determine who was correct and who was more accurate. I say more accurate because there's always some discussion that goes back and forth with that. So they submit that to me monthly. I have 2 PI collectors, so I get about 60 charts or so that we review. Recently, our accuracy has been 90 to 100% each month. There's not really a huge issue. I'm not finding too many fallouts regarding the accuracy. But when I do, I usually follow up with the individual. So that's sort of our process, follow up with the individual and find some things to where they're, how they determine their ESI level. I found some things as to well, they based it on which provider was working that day or things like that. So we just sort of discuss those issues in our nursing, our unit staff meeting. Of course, I don't say the names or the nurse's name, but I just present sort of the situation and ask questions about what level would they assign and why. And that seems to be helpful in learning, experiences and for the other staff who attend our meetings. We have any huge fallouts, I work with the QAPI risk manager regarding RCAs or anything that needs to be worked on if our process is failing, right?
Good deal. That sounds great, Nicole. Sounds like that discussion between your nurses is probably helpful in gaining some consistency in your ESIs. So
levels.
Yeah, for sure. Thank you so much for sharing that information. And we will have more opportunity for service unit sharing in May. So I feel like this is a great place to showcase things and to learn from each other. So thanks for doing that, both service units today. So we'll move along now to the left without being seen measure and talk about that just briefly. Go ahead to the next slide. So left without being seen, very common and very much tracked across the board. The overall rate for left without being seen was 5.5%, which is a little bit higher than the target of 4%. So a little bit of work to do there, but not too off target. So that's good. The one area that does need some improvement that we know and we expected was the left without being seen 2-day contact, just because it wasn't really standard process yet across the board to follow up. So this will be an area, again, with a discharge planning follow-up with patients, that'll be an area of focus moving forward. So go ahead to the next slide. So the first measure in this measure group was that 100% of patients would have follow-up contact within 2 days. Again, to be consistent, we did reduce that to 90% of patients. So again, trying to account for patients that you may not have contact information for, or also may not, because there's just a high volume of patients potentially to follow up with. So hopefully give you a little bit of leeway there. So your numerator would be those that had a documented attempt to phone contact, staying consistent with the discharge follow-up. And then the denominator is just the department patient visits who left prior to being seen by a provider with the discharge code of left without being seen or did not wait. So the measure target is 90%, And I apologize for that timeline being cut off on this presentation, but it'll be on your slides. July of 2019 is the goal to reach that target. So go ahead to the next slide. So this is just the rate. I do want to point out that they are working, IHS headquarters is working on pulling this information as an electronic clinical quality measure, and it is consistent with CMS outpatient measure number 22. So this is the percent of patients who leave without being evaluated by a physician, nurse practitioner, or physician's assistant. So there wasn't really any changes to this definition. We just wanted to point out that they are developing this measure so that it can come out of your electronic CQMs, and it's consistent with CMS measure outpatient 22. So no other changes there. And you're close to meeting that target of 4% by July of 2019. Go ahead to the next slide. And the next one. So the baseline for the ED throughput time was, the overall throughput time baseline was 109.5 minutes, which is less than the median target of 120 minutes. The overall median for medical screening exam was 35 minutes, and the overall median for triage was 8 minutes. So I want to go ahead to the next slide and point out a few things about these measures. So first of all, again, IHS headquarters is developing the electronic clinical quality measure, CMS outpatient number 18. So there's an overall measure with 18, and then there's 4 subsets. I'm just pointing that out to you because we are working through right now with IHS headquarters on how to make this aim consistent with that measure that they are developing. Because right now, this measure would not include transfers. It would only include discharges to home health, or nursing home, because we recognize that transfers and admissions are probably going to have a longer length of stay in the emergency department and could potentially skew that data. So we're trying to align these measures a little bit better. So if you want to go ahead to the next slide, we'll go through those right now. So the original measure was to just establish a baseline for the median time. And that's the other thing that I really want to point out here, that a lot of facilities were reporting average time, and the actual measure is median time. So that's a key point in your data collection, because that means your data is looked at just a little bit differently. And if you need any help with that, we can definitely do that. So the original measure was just to establish baseline. IHS indicated they wanted to continue monitoring of this measure to be consistent with the rest of the measures through at least July of 2019, potentially longer. I'll go ahead and go back to that slide. So you're going to monitor the elapsed time in minutes between time of arrival to time of triage. And your included population would be emergency department visits with a discharge disposition of home health, or nursing home. And right now we're working through with IHS, some of those CMS measures include transfers. So we're trying to work through how that's going to look. Go ahead to the next slide. So the updated definition for this, again, was just the median time of arrival, and that they're continuing monitoring of this measure into 2019. So you're monitoring that median time, or that elapsed time in minutes between the time of arrival to the time of medical screening. We also understand that this one is a much more difficult measure because sometimes the medical screening exam, the time of medical screening exam, is not as precisely captured. Some institutions were monitoring time of note entry, so this one's going to take a little work with your PATH project managers to maybe get some consistency and understand what your time of medical screening exam is going to look like in your facility. So the last one is just the overall length of stay. So there are not targets for the other 2 measures. Those just play into this target of overall less than 120 minutes. So again, median time from emergency department arrival to departure from the emergency room for patients discharged. This is trying to be consistent with measure CMS measure outpatient 18. So this is taking into account that entire length of stay in the ER which has a target of less than 120 minutes, which is why we are thinking that the intent of this is to measure the discharge disposition of home health, or nursing home. So that's kind of, where we're headed now, and again, working with IHS headquarters on the rest of it. So go ahead to the next slide, and next one. So your ongoing PATH data submission. So we are working with IHS right now to develop streamlined approach for you to submit data to Health Insight in the PATH project. The solution for reporting that data to us will be available to receive data the first part of April with our demonstration at our next LAN. You should right now continue to collect your data internally on a monthly basis and start making improvements and tracking those improvements with your PATH project managers. We're going to need you to identify at least 2 data submission staff and provide their contact information to your PATH PM by March 15th. The first data submission deadline will be April 12th for January, February, and hopefully March. So don't throw anything at me just yet. If March is not doable, just let us know. So I'm going to go ahead and turn it over to Sarah. Hopefully I've left enough time for her to cover what she needs to cover.
Yeah, I think we have enough time. I'm Sarah Leake, and I've been working actually with Billings area IHS for many years on meaningful use, PI, and all of that, and also get the chance to work with some ED dashboard activity with Leslie Racine. I'm doing the PATH on the AIM3 on the data analyst side, and some other activity with PATH too. So what we want to talk about is the data collection reporting overview. So there's a couple different ways that that we have identified to submit data. So most of the facilities use the ED dashboard, and some of you don't. We have other ways of doing the data collection on that. But part of the data will be through ED dashboard, and other will be through a manual submission method that Mary said we should be able to demonstrate in April. So the left without being seen in your ED throughput is, you can use the ED dashboard report in order to calculate that data. So that's what we will be doing, is getting that data through the ED dashboard for those of you that have it. The others will be a manual submission for discharge, ESI, and then the left without being seen follow-up, we still believe that that should be through a manual submission. And our idea is the second Friday of each month, starting in April, is when we're hoping that we can get the data submitted to Health Insight. This is a diagram basically of where the IHS hospitals will be pulling this data through the EHR. Some of the hospitals already have their analysis tools. If you have them, then that's an opportunity to go ahead and give, not necessarily send the ED dashboard data, but send the information in a numerator denominator form. But you would send that securely to Health Insight, and then they will take all of this data and do either analysis if they need to, or pull the data together to get aggregate data that they can report to IHS headquarters and also the CMS quality. For this particular PATH project. Also, this data will be aggregated, and the PATH managers will have this data to review with the area offices and the hospital service units. So that data can be used for your further analysis, for improvement processes. So it is a cycle. We're not taking the data and just holding on to it. It's going to be used for all of this improvement activity. So the collection process for left without being seen and ED throughput would be that the service units will run their ED dashboard report. Remove any of the PHI and information that is not required. So obviously we want no information that we don't need in order to do the analysis and send back. And then this will be submitted through the secure FTP. Health Insight will run analysis, calculate your left without be seen, and ED throughput, of course, again, the median, because Mary had stressed a lot of it's median, not averages. Also will identify, based on what logic is used, the records that are outliers, or what some information that just couldn't be used. And that's some feedback for you to determine, where are we putting something in the ED dashboard? Is there some way that we need to put it in differently so that we get all of our data in there correctly? And then this information again will be returned to CMS, IHS, and the hospital and area offices. This is probably a repeat for several of these service units, and there's a lot of experts out there, but I wanted to just give a general idea of how you would generate that ED dashboard. And if you already know and you have tips, please share them with us. But I want to give some credit to Leslie Racine because she walked through this with me from Billings area office. But you would log into the ED dashboard, select the manager, then you would select the report. So that report you would run what was called the central log. And this can be run by admission or discharge, and you would enter the dates. And as Mary had mentioned, we would like the monthly data. So you would put January 1st through January 31st, run the report. And what we've chosen is to go ahead and choose admission so that we're consistent across all of the hospitals. And then this will generate the central log for your hospital. So once the report is complete, my understanding is it's a bit clumsy. You can't download it or you can't export it into Excel. So what you will have to do is actually go into the report, open a blank Excel document, and then take that dashboard information that you get from the central log, copy it through Control-A, right-click, and then copy-paste it into your Excel worksheet in the top left-hand corner, A1. So if someone knows other than that, please let me know, get a hold of me. I'm always open to suggestions and improvements. But this is how you would copy that data into Excel and have it ready so you can change the data or remove some of the data. Next page, please. This is a sample of what the data is. It's in 2 rows, of course, because it goes across in all of those columns out to AH. But I've boxed in orange highlight that those are the areas that we don't need the information. So you would go in and take all of those boxes, clean them out, and remove that data because that data is not necessary for analysis. As you can see, the patient chart, age, etc., anything diagnosis-wise, nursing, and just remove that. And then once you have that cleaned up, save the document, and then this is what would be sent secure to PATH Health Insight. So there are alternatives. I kind of think I touched upon them a little bit. So the one way is extracting and sending your log report so PATH can do that analysis for you and figure out the median and any kind of outliers. Or if you're already calculating with a tool, an analysis tool that you have, you can manually submit that in the submission tool that we develop through review with IHS and CMS and our PATH team. So you would put the numerator, denominator, and if you do not use the ED dashboard at this point, you can use the chart audit tool and submit manually also. But again, you're certainly welcome if you're in the middle of ED dashboard, or if we can probably get the resources set up with you if you want to start using ED dashboard. Next page, please. There are several resources out there now for ED dashboard for IHS personnel. There's the cloud training. And this would be through your IHS login. And on the right-hand side, I did a little cut-paste of some of the training titles out there now. Tony Milkamp is an expert on the ED dashboard, and he does do office hours. He'll pull up any questions you have, go through them. So this is a great resource also if you have questions. And again, please reach out to the PATH project managers or Mary or myself on the AIM3 team, and we will do what we can to help work through getting this data and improving it. So thank you very much.
Great, thank you, Sarah. Go ahead and move to the next slide. So your next steps, I know that we have covered a ton of information today, so I hope that we have not overwhelmed you, and hopefully this was helpful in clearing up some of your questions. So your next steps are to just review the updated measure definitions with your improvement teams that are available in this slide deck and through your PATH PMs. Your PATH PMs also have baseline summary reports that would have some individual hospital data that's been de-identified and masked, but it also allows you to benchmark a little bit amongst yourselves. So hopefully you've all started collecting some data as of the first of the year and integrating that into your existing QI processes. You don't need to wait for your submission reporting tool for Health Insight to start these, to start your own data, internal data collection. Identify your priority areas of improvement. What's your low-hanging fruit, and what are your most critical processes and patients that, especially with those follow-up pieces. And identify your additional support that you need from the PATH project and let us know. Go ahead to the next slide. So because we really want this to be an interactive project and move the whole system forward on all of these measures in a supportive fashion, we're actually going to let you guys give us a status report at the May 1st LAN. We've created a PowerPoint template. We'll probably have that due around mid-April. Haven't really set a hard date on that yet. And those are available will be available and distributed to the quality managers following this LAN through your PATH project managers. So in May, again, it'll be a project status. You will not have to have met all of your targets. And especially if you're struggling, we want you to bring your concerns to the table and ask your partners and your peers for some best practices. So we'll have all of that put together. So go ahead to the next slide. So we have a couple of polling questions for you today. We're wrapping up, and I know there's been several questions in chat. We have about 6 minutes left, which is, you know, a lot faster than we went a little bit over, but that's okay. We're still making good time. So if there are some questions you'd like in chat, go ahead and do that. And there's been a lot of questions around that discharge planning template and if that can be shared. So we'll reach out to ACL and figure out the best way to do that. Might be through the CACs and through their networking. So let us know. We'll leave the poll up for a little bit longer. So go ahead and answer those to the best of your ability. The polling questions that we're asking you now will help us in the next session in April that's coming up with our subject matter expert, Dr. Acid. So trying to key in on what would be the best information for her to share. So I'm getting the question from Crown Point, when will the updates be available to service units? Which updates are you specifically referring to? The measure updates are available now. Is that what you're referring to? Could you please clarify? AIM ED updates. So just the measure updates, they're available in the slide deck immediately following the LAN. Is that right, Francesca, when these go out on that resource page?
Yes, so these will be available on the Health Insight PATH LAN resource page.
So like I said, our next LAN will be April 3rd, and Dr. Assard works in a very busy emergency department in Denver. And I spoke with her earlier this week, and she is very excited to be helping with this project and be our subject matter expert. She also serves on the emergency nurses professional organization as well, the ENA. So she's a great resource for us and has lots of ideas and feedback for you. And she's very grounded. So she's very realistic about what you're facing every day in your important, with the services that you're providing across the country. Okay. And I think that's the last slide. I don't see any further questions in chat. So let me make sure. We will summarize the discussion in chat as well, and also have that available to you because there was some good discussion and Q&A that went on while we were talking. So there was one question I just wanted to follow up on that Christine Gilliam had asked, what was your average daily ED volume and throughput time? And this, I believe, was a question for ACL. Are you comfortable answering that question in this group, or would you like to follow up with Christine?
Yes, okay. Melissa will answer that.
Okay, thank you.
So our average throughput time that we got for 2018 was little over 120 minutes. This included everybody, including our transfers and our left without being seen and everything that came through.
Okay. And then what's your average ED volume daily?
So our average ED volume average is probably about, let me see, the last one I checked was about 45 in January, and then December it was like 55, and then I haven't done February yet.
Okay. All right, well, thank you for answering those questions for us, and I believe that is all. Francesca, did you have anything else to?
I did the average.
That's all. Thank you, Mary. Thank you, Sarah, for speaking, and thank you to our 2 service units for your invaluable input to this discussion. I just want to reiterate that this session is being recorded, and we'll be sending that out briefly sometime this week for you all to share for anyone who is unable to make it. And other than that, thank you all so much for being here. We very much appreciate it, and we hope to see you at our session in April with Dr. Asid. Have a great day, everyone.